Hi, everyone. Hope you are all doing well. Welcome to our Quality of Life and Advanced Care Planning webinar. This session is provided by the Ontario Rett Syndrome Association. And before we begin, I would like to let everyone know that we have additional support and guidance on our website for you to look at your own space and time. You can find that information at rett.ca. We will also include this presentation as a resource. We are happy to answer any questions at the end of the session, or you can just paste any comments or questions you have in the chat and we'll monitor that on our end. It is my pleasure today to introduce you to Dr. Joanna Humphreys. Dr. Humphreys is a pediatrician with expertise in pediatric palliative care. Dr. Humphreys completed her pediatric residency training, community pediatric fellowship, and palliative care fellowship at the Hospital for Sick Children in Toronto, Ontario. She then worked at the Hospital for Sick Children as a staff physician on the pediatric advanced care team and as a general pediatrician at Credit Valley Hospital. Dr. Humphreys is now at McMaster Children's Hospital, working with the Quality of Life and Advanced Care team. Her interests include physician wellness, advanced care planning, and childhood grief. Of special note, Dr. Humphreys also worked at our Holland Bloorview Rett Clinic and is well versed in all things Rett syndrome. Thank you so much for joining us today, Dr. Humphreys. We look forward to hearing your presentation.
Thank you so much, Sabrina, and thank you to the Ontario Rett Association for having me here to speak today. Children and their families, children with Rett syndrome and their families are very close to my heart after a year spent intensively at the Rett Clinic in Holland Bloorview, and will continue to be throughout my life without any question, both personally and professionally. I am going to share my screen now, if that's okay with everyone. Okay, so I'm really excited to talk about two topics that are near and dear to my heart, both quality of life and advanced care planning. And I hope by the end that I'm able to express my thoughts about how these two very important topics are so intricately linked, and why, while we're focusing on quality of life, we often also need to focus on advanced care planning. Just a very brief land acknowledgement. This is in no meant to be something of a token. I do truly appreciate personally the lands that I live and work on, and the Indigenous populations that came before me and share this land. Reconciliation is a long process and involves effort from all our parts. I know we all sit on different lands, and I hope with all the movement in the world that this reconciliation process continues to create equity within all of the communities that live here. So who am I? I think Sabrina really talked about this, so I won't belabor this point, but I'm a pediatric palliative care physician. And so quality of life and advanced care planning are right in my purview of what I do every single day. Personally, they are something that I work on both with my patients, but in the education realm and research wellness realm as well. And they are in what I believe to be the mainstay of the work that I do, and really truly should be the mainstay of work that all physicians and healthcare practitioners do when caring for children with serious illnesses, life-living illnesses, and developmental conditions that affect children's quality of life. So I'm going to start a little bit and talk about quality of life. If we had a few more participants here, I'd kind of want all of you, and maybe kind of Barb and Larry, you can just put in the chat for us, you know, what you think of as quality of life and what brings you quality of life. Because as I would like to discuss, we know that quality of life is very subjective. It's very dependent on the individual, and it is subject to change. And especially when we are thinking of children who have various developmental problems, life-limiting illnesses, genetic conditions, or really any sort of chronic disease, we know that quality of life is so subjective, not only for that individual child, but to their family. And a lot of that is based on so many different factors that child faces and their family face. So Larry has put in holistic wellness. Yes, we're going to talk a little bit about holistic advanced care planning, but I literally love holistic wellness, finding joy in small things. Thank you, Barb. And I would like to think that everyone who is on the call would say something different. And I do wonder if we were to think of all the children in our lives with Rett syndrome or some sort of chronic disease, what they would tell us is important for their quality of life. Whether they're able to verbalize that or not. And I think that would just speak wonders actually to the diversity of what quality of life is for every human being. So when we think of the things that impact quality of life, I didn't pull this from a textbook. This is from, practical life. And I don't know, Sabrina, Barb, and Larry, what you think, and if you would add anything major to this list, but it's physical health. It is what is happening. If we think of a child with a chronic disease, where is their physical health along their journey? How is their mental health being supported? And that's not just for neurotypical children. That's especially in my mind for children who are not neurotypical, because it's so much harder for them to express their anxiety, their mood. They are reliant on their caregivers to be able to pick up on their cues. I don't know about you guys, but some people in my life would say they can't necessarily tell what's going on in my head when I'm having a good day or a bad day. And it may be the same for children with chronic disease. There's a bit of protectionism that you protect the people around you. And just because a child has a developmental delay or chronic disease, it doesn't stop them from doing those things. Family health is huge, physical, mental, what is happening within their environment. Their environment is not just that family home and the people are in it, it's their schools, it's their daycares, it's what's happening at Ron Joyce Developmental Center. It's COVID, it's, are we able to go into hospital? Did they get treated well when they went in for their physio appointment? How are they treated on the streets? How are they treated when they go into a store? All those things impact quality of life. Social health, a lot of this can be the social determinants of health. So do they have shelter? Do they have the finances? Do they have enough food? Do they have the equipment that they need? Goodness me, I know that can be so difficult in so many children. Eyesight, is something that we use so much in the Rett syndrome population. Maybe some families can afford it, others can't, and that could strongly impact quality of life. And last and definitely not least, there's no order, as we talked about, everything is subjective, but what supports are available, financial, physical, emotional, both to the child as well as the family. So quality of life is this really complex melange. We know that some things, often kind of trump, other things at different times in life, but that's very, very variable. And if I were to think of a lot of the problems in children that I see, and specifically, thinking of children with Rett syndrome, difficult symptoms that cause suffering. So pain, immobility, gastroesophageal reflux, anything that is going to make their day a little bit worse, or potentially a lot worse. Time in hospitals, contact with medical professionals. If a child is constantly being admitted to hospital, has to go into the ICU, or is constantly going back for appointments, that can significantly impact the quality of life of a family or a child. Ability to get what you want and need from the system. This is a big issue right now. Nursing. Who's getting their PSW and their nursing staff right now? Who is a pediatrician or a family doctor that has time to see them in a short period of time? This isn't no one's fault, but is our system right now, and how difficult that is for families to exist within it, and the frustrations that come along with that. That's a big thing. I'm seeing a big rise in that's impact on the quality of life. Autonomy. A, for the child to be able to kind of express themselves, to do things that they want to be able to do. And also the family, the autonomy to feel that you can be making medical decisions for your child, that you're not beholden or reliant on physicians who may not understand your whole story, may not have the time to understand your whole story to be able to help you advocate for things that are right for you and your child and fit in with your goals of care and what's important for you. Social interactions, I don't need to preach to anyone how in the last few years, just that general social interaction, school, daycare, even if it's just getting to physio once a week and having that hands-on touch. There are so many different common problems that I see affecting quality of life. And I'm just looking at Larry's comment, jeopardizing activities of daily living, being dependent. Yes. And that's something, again, I love that comment, Larry, because again, that's something that's so subjective. If I suddenly were to develop an illness where I was completely dependent on someone else, that would have a huge effect on my quality of life. And this is where I often question, at what, for our beloved children with Rett syndrome, how does that play out for them? Maybe some children are at a stage where that they don't even know, aren't truly aware of that degree of dependence, and therefore it doesn't affect their quality of life. Whereas some children may be at that stage where they really want to do things by themselves and have just enough capabilities to do so, but then can't because of one problem or the other. So for one child, that may cause no problems at all, and for the other, it may actually cause a lot. Any comments right now, Barb, Larry, or Sabrina, just about quality of life and some of the things that we see that have an impact?
No, I think you've covered mostly all of it. Like, I know, especially for my child, COVID really she deteriorated through the last 2 years, more so just because she couldn't interact with her peers at school and do the social things that we were accustomed to doing and giving her that great quality of life that we want to give her. So I know definitely our family took a big hit this last 2 years. And actually, even this week, she's at camp and she's so happy. She came home yesterday, very, very happy. And it was amazing to see. And this morning, she was ready to go out the door. So quality of life is a big, big staple in our family, and I'm sure in many family that have children with Rett syndrome for sure.
Thank you, Sabrina. And I think those are some of those things that sometimes we took for granted before COVID, and it's amazing their impact. We just kind of see them as a staple, which we would always have. And so I think it just speaks to all the different layers and kind of Maslow's hierarchy of needs. We kind of forget how important, community and social interactions are to our race. And I think that often goes even more for children with chronic diseases. So I'm going to talk a little bit about suffering in the context of quality of life, just to spin it a little bit differently, because everything that I've said, I think you guys, if you were putting together a talk for quality of life, you could probably come up with that stuff too. But when we look at one of the World Health Organization's definitions of palliative care, they define it as an approach that improves the quality of life of patients and their families facing problems associated with life-threatening illnesses. In pediatrics, this is a very much an adult-focused definition. It is life-threatening. It's also life-limiting. It is also things that affect the quality of life, or diseases and chronic diseases that affect the quality of life. Through the prevention and relief of suffering by means of early identification, impeccable assessment, treatment of pain and other problems, physical, psychological, and spiritual. And so, I think we really see this huge link here between improving quality of life and relief of suffering. I'm going to talk you through a little philosophical model just to kind of get your brains whizzing a little bit. So, this is really the challenge for me in pediatric palliative care, is finding out where the pain is coming from. And that's not just in the hip or reflux, that's total pain. What is affecting quality of life? Psychosocial, spiritual, mental health, physical health, and try to relieve that suffering by taking away some of those things that are negatively impacting quality of life. I'm hoping that if I can relieve that suffering, I can naturally improve quality of life. So So I will have to say thank you to Dr. Greg Zaninga, who is one of the physicians on my team. And this is a model that he has really conceptualized and that I'm stealing from him today, and I steal from him a lot. Is this idea of, the scale of quality of life and suffering. And, if we think about it, from a suffering perspective, could you ever say that you have a finite amount of joy or happiness? Would you ever say that you've maxed out on happiness? All of you, does that ever feel like something that you could say, like, no, I'm 100% at the happiest I will ever be? Hopefully I'm seeing some shaking heads, Sabrina.
I wish.
I wish, yes. Or I don't wish, because I always love the idea that no matter how happy I am today I'm so happy speaking to you here. Maybe next year I'll be able to speak to you in person, and that will be even better, and I'll have even more joy or happiness. And I think the same goes for suffering, is that unfortunately there is, it is not finite. It is, that's why we're using the infinity signs here, is that unfortunately with all the different layers of suffering, there is no finite amount of suffering. So we think of suffering, quality of life, and then in the middle, you can think of neutral, where you're not suffering. So there's nothing necessarily that's, causing extreme suffering, but you don't necessarily have quality of life. And kind of this is just taking it a little bit more into lay terms. Quality of life is when you're enjoying life. No quality, no suffering is having life, and it's negative when you have suffering. And I think this is what we're constantly trying to do in palliative care, is we are trying to reduce the suffering. So come up on the scale and go higher up into that enjoying life and seeing what we can do with that. Sorry, I'm just constantly trying to move around my pictures so that I can see my whole screen. So again, here, if we look at this as like a quality of life scale. So down at the bottom is just extreme suffering. Up at the top is enjoying life. And we can kind of look at the concept of, relieving suffering with kind of standard medical treatment, trying to treat pain, treat various different ailments that are affecting suffering, again, in all different realms. And then looking at taking things even further, looking at optional resources to actually enhance quality of life. So a wish trip, for example, is not going to necessarily relieve suffering. Although in a patient I saw earlier today, I wonder whether it will. And then looking at, how can we actually enhance quality of life? So it's remembering when we're looking at quality that it is the relief of suffering, but also the enhancement of quality of life. What is important? What drives quality of life? And how can we get more of that? As well as how can we take away the things that are causing suffering? So you can look here again, if you have a headache, we want to give you some pills in order to try to relieve your headache. Maybe we're going to give you some free movie tickets, and that's going to really enhance your quality of life. So here on this scale, we are hoping that majority of our patients and majority of children with Rett syndrome are living in that scale where we are looking at how we can maximize quality of life. If we think of neutral as kind of the minimum quality of life, what are the things that are going to really, really improve quality of life? Is it, as maybe Sabrina, you were talking about, smiling and interacting? Is it just having that contact with people? To be able to talk, walk, feed? What is it that is driving that quality of life? How can we assess it? And then how can we work to improve it? And then we have a little bit more of a, I would call it a humanistic view of this quality of life scale. We can look at it from the really basic things like feeding, talking, walking, but then we can also look at other things that can have a huge impact on quality of life. And especially for some children who are not able to do those things like feed, walk, talk, we often look at the scale in a very, very different way, in a more holistic way, maybe, Larry, you would say, about the ability to give love, to smile, to hold a hand. that ability to feel loved, and even just that ability to be surrounded and be loved. So I think when we think about this, we can oftentimes get really wrapped up in the kind of the biopsychosocial model, but we also need to remember that some of the basic human needs, which have a huge impact on quality of life, are more simple and around being loved and sharing love. Just going to check the chat. Pain and suffering are two different things, but go synonymously with each other. I completely agree, Larry. You know, we learn that symptoms and treating them can affect quality of life, but they're not always synonymous together. And maybe before I go on to this, any questions about that model? Any questions about kind of quality of life and what that means to maybe you, your family members, or any questions about that quality of life scale and that kind of more philosophical concept of suffering?
How would you measure it?
Great question, Larry. I think this is one of the things that in healthcare we don't do well enough. I measure it by asking. I measure it by asking a family about the quality of life of their child or adult or whomever I am dealing with, and waiting to hear an answer and caring for that answer. Not asking 3 medical questions about pain. What is it on a scale of 1 to 10? Where is it? Does it radiate? I am asking about how does this pain affect your quality of life? I am asking a more detailed, deep history into the psychosocial impact and factors that impact quality of life. There are some quality of life scales. Sure, you could measure them. There are pain scales. There are lots of different things. But for me, how I measure the quality of life of the children and families I work with is simply by taking the time to ask about it and to take the time to listen to their story. I was listening to this phenomenal podcast earlier today where a doctor from the States was talking a little bit about her journey. And she said, I've had X disease for 52 years and I've had 8 surgeries. That does not tell you about my story. And so I think this is where the patient narrative, the patient story, is hugely important in assessing quality of life. And Larry, I can definitely look at letting you know about if you put your email in the chat, and maybe Sabrina, if you could write the email down and send it to me later, I can send you some information about quality of life scales. If I had more time, I would have done more of that today. So I apologize for not getting into that.
I think just to tag on to the question you were asking, from my perspective as a parent who has a child with this neurological disorder, I think quality of life is the only thing I can control. I can't control everything that's happening with her body and the way that her body is fighting whatever issue that she's having, but I can control how what we provide for her to keep her safe, to keep her happy, to maximize her life the best way that we can. And I think in a world where you try to control, like us as humans, we do try to control a lot of things. That's given me back some power that I felt that when I got that diagnosis, I no longer had. So it's just a different way for me to think, a different perspective that I am grateful early on that I realized, and it really changed the way that I reframe the way that I was thinking and reframe the way that my family is living their life right now. And it's giving me some kind of peace over the diagnosis. And that's just my personal story and how I feel about quality of life.
Sabrina, that's beautifully said. I love that quality of life is something that you have control over. And that's why I think, Larry, from our perspective as healthcare professionals, we need to listen to our families about what, Sabrina's told us that that's what she takes control of. But how does she take control of it? What's important? What is having that impact for her? And it is only then that we can really, truly measure it, when we take the time to understand it. Because as you said, it is so individual. I'm going to try to I noticed we're at the 30-minute mark, so this is perfect. I'm going to try to transition into advanced care planning, but I want to tie the two together because for me, this is how I talk about advanced care planning. So all the work that we're talking about now is focusing on the quality of our life, of our child's life, or quality of the life of a child with serious illness, with Rett syndrome, and we're looking at that kind of day to day. What is happening? Are we going to Canada's Wonderland today? Are we getting that new wheelchair fit? Are we doing some social interaction? Are we seeing the doctor to treat for pain? And that's all kind of in the here and now. And advanced care planning for me is a way that we can work on protecting the quality of life of our child in the future, no matter what comes. With Rett syndrome and many diseases, many chronic illnesses, many neurodevelopmental diseases in children, there is so much uncertainty about the future. If we can look at the future, talk about it, plan for it, and by plan, you'll see I don't mean advanced directives or anything like that, but have potential things laid in place for things that could happen in the future. What we are doing is we are protecting our child's quality of life in the future so that if something were to happen to them, we have things set up that are based on the values and the goals of you and your family, of my patients, so that if something happens, if a child were to become seriously unwell, if a child were to need certain interventions, we have already been working on knowing what we want so that we can continue the best quality of life possible, no matter what is happening. Yes, that quality of life may change, but we want to make it as good as possible if something in the future were to happen. We can't do that if we're not talking about them, problems, if we're not recognizing things that may happen in the future, because a lot of these things happen very acutely in very quick moments. And so we can't always preserve quality of life if we haven't talked to them beforehand. So that's the way that I see advanced care planning and why to me it is so important. So this is a postcard that myself and others through Holland Bloorview, and you'll see on this next slide all of the different organizations that have got behind it. So through the HPCO in Ontario, where we are specifically, we find this so important that we created this pamphlet for families, specifically around advanced care planning, but not actually even naming it as such. It's about thinking about the future. Thinking about the future is important, even if you don't have all the answers. This information may help you get started. So for us, we really wanted to look at advanced care planning in a very holistic manner. I know, Larry, you mentioned holistic quality of life. And so you'll see here on this slide that future health and kind of the stuff that we normally think about advanced care planning is definitely the biggest bubble, but it's just one bubble. When we want to protect our kids' quality of life in the future, we want to think about their fitness. We want to think about their function. We want to think about their friends and fun, their family, long-term caregiver education and support. We need to keep our caregivers, with their life vests on, keeping afloat. We need to make sure they have good financial housing and planning. And then we need to make sure we're talking about possible future health and medical needs and preparation in the case of severe or life-threatening illness. So I'm not taking away from the importance of that green bubble, but it's remembering that there are lots of different topics that we can do in advanced care planning. And by looking at it in this way, we take a more holistic approach. Again, how do you do advanced care planning? Oh, there's a little 3 on that screen, sorry. How do you do advanced care planning? I think when we talk about advanced care planning, to me initially, I thought like, oh, so that means I need to write down my thoughts. That means I need to tell the doctors exactly what I want if my heart were to stop. And from my perspective, that's completely untrue. The first thing I want to do in the process is just to start thinking about it. I want families to start thinking about things that may happen in the future. And if as a healthcare professional, I think that you're not thinking about it, then I'm not very good at my job. I know that as a parent, or I can't even say I know, I can't imagine that you wouldn't be thinking about the future for your child because that's part of your job as a parent. It's part of our jobs as healthcare professionals. So it's really trying to think and then think about what's important. Think about goals. Think about goals of care. What is important to maintain my child's quality of life in the future? Then talking about it. What if Susie were to become more unwell? I promise that's not a real name. What if, someone were to suddenly end up in the ICU? What if we lost the ability, our child lost the ability to walk? What if? And actually talking about it. Talk about it with your family. Talk about it with healthcare practitioners who are important to you, and then kind of start that planning process. There's a lot to learn about. There's a lot to learn about why you would make certain decisions. What information do you need in order to help you make any decisions? And to me, those first 3 steps are all that are important. If you never make a plan, if you never share it, it doesn't matter. As long as you've gathered the information you need, you've talked about it with the key people in your life, and you're really thinking about this on a regular basis. Plans can definitely be made for the future. Nothing is set in stone. If there is something that is so vital to your child's health or quality of life that we do want to put it into place. And obviously being a palliative care doctor, I do have families like that they say, a feeding tube for us would not be something that we would want for our child. Going to the ICU would not be something that we want. Chest compressions, if their body were to become so unwell that their heart were to stop, that would be telling me that we couldn't get our child back to the baseline quality of life that they were experiencing before. And then obviously, if we are making a plan, the hope is to share it with the right people. Not everybody. You don't need to blast it from the roof, but the right people who need to know in order to make sure that the quality of life can be preserved no matter what is happening. So this is a postcard that should be available soon on the HPCO website. It's called, the website is actually just advancedcareplanning.com. And we hope to have this available very soon for people and hoping to start use it in clinical practice very soon.
Part of my story is that sorry, I'm having trouble with my internet, but part of my story is that I was responsible when my son was young with his physical, emotional, mental, and spiritual quality of life. And then I got diagnosed with a brain tumor and he went into care, and my whole way of supporting him went from being physically hands-on to having to advocate in a different setting for him. So when you're doing your advanced care planning and you think about changes, you have to include yourself in that change, because you don't know what's going to happen with your son or daughter, and you don't know what's going to happen with you. I don't know which way of support was harder to do. I think they were both equally challenging, and so very important.
Thank you, Barb, for sharing that story. And I can't imagine how hard that would have been. And as you'll see later on, that's one of the things I think is so important in advanced care planning is also planning for illness for the caregiver, as you unfortunately experienced. And Larry, thanks to you also for sharing your story about your daughter who's a survivor of retinoblastoma. And you mentioned advanced care planning with goals of care. That's the biggest thing. And that's what, as a health provider, that's what I do, is trying to figure out what are the goals of care. And those are going to differ for every family, every child with Rett syndrome, even if we're looking at that same future problems based on their goals of care, their individual family values. They're all potentially going to have very different goals, which may lead to different outcomes. And so that's why it's so important to think about it and talk about it. I'm not going to play this video right now due to time, but if at the end we have a little bit of time, we can come back and play the video. But Sabrina, I can also give you the link so it's available to anyone. But this is a horrible, long, horrible link, but again, we hope it should be available on the HPCO website soon.
Yeah, that would be great. This way we'll link it up to our website so families can link onto that site as well.
Okay, I'll send you all that, Sabrina.
Thank you.
So just to get into the little bit of the nitty and the nuts and bolts of advanced care planning, I've talked through it a bit, but truly for me, it's a process of establishing goals of care. As Larry said, it's an extension of discussions about treatment plans. So not just you need a feeding tube now, but what if you need a feeding tube in the future? What if that feeding tube in the future, unfortunately, doesn't work because of progressive problems with the gut? So it encompasses both kind of short-term and long-term health goals and treatments. And I think that's what we need to start doing. It's going into that preventative care. It's a process to help plan for the future, medical decisions, difficult decisions prior to that moment of crisis. So Barb, I'm sure when your diagnosis, there was that kind of moment of crisis, not something that you would prepare for, having a serious illness yourself, but the type of things that we'd like to try as the best of our abilities to think about before that moment of crisis. And it may or may not include drafting of a formal advance directive. Advance directive is a very adult focused word, but sometimes my advance directives, I'd say maybe even 50-50, say we want to do everything. But then when actually you go into a hospital and your child's seriously ill, you can say, we've thought about this, we've talked about this, we want everything for our child. According to a 2008 Canadian Pediatric Society statement, this is a standard of care. So this is something that every child should be able to receive when they go to their doctors. It is a longitudinal process. It is not something you do in one sitting or once. It is a continual conversation. It's appropriate at any point following the diagnosis of a serious illness, no matter what that serious illness is or that chronic disease is. Ideally, it's implemented early. It's continued throughout the life course or the journey of the disease. And ideally, it focuses on quality of life and what's important. Equally, that is easier said than done. It is very easy for me to put up this slide. It is very hard for this to be used in practice. Larry asked, who would be the final decision maker for the child? So that would be the substitute decision maker. So that would be the legal parent or guardian, or if there is no legal parent or guardian, it would be, if a child is ward of the state or adopted, it would be, whoever is legally the decision maker. But as the child gets older, I think in different countries, that will be a very different rules and legislature, but at least here in Canada, it's showing that a child has capacity. So a 14-year-old has capacity, can be the decision maker for themselves. If a child is felt not to have capacity, then it goes to the substitute decision maker. Great question. Thank you, Larry. And, I talk, I know I'm very grateful I'm talking to your community, because I find Rett syndrome, the Rett Syndrome Society, and so many families I've worked with are so open to advanced care planning. But especially, when we look at, who are the children that we worry about kind of even just not surviving childhood or having more kind of severe illnesses, we know that this is really, really linked to overall disability scores, which is very much based on motor function. So we know that the worse the child's motor function, the greater the risk of mortality, so death or morbidity, which is medical problems. And we know that that is quite linked, unfortunately, to motor skills. And that's why in children with Rett syndrome, we see such a variety, because the motor disability is so extremely different. We have some children who are wheelchair bound. We have some children who are fully ambulatory. Some children who are still able to do some purposeful movements, some who aren't. So who do you go to have your advanced care planning conversations? Who should have these? Really, truly anyone, your primary care providers, your specialists, physicians, NPs, your developmental team, your complex care team, obviously your palliative care team. But the people I find who mostly have them, which is not my ideal, is actually the acute care providers in the emergency PICU, NICU, or hospital providers. Unfortunately, if you were to look at all the advanced care planning conversations that are happening, unfortunately, most of them are happening here. And my goal is really to try to shift that up. So these are advanced care planning conversations, not right now planning conversations.
You think that's the reason behind that is because of the stereotype around palliative care, and how the stigma around advanced care planning, and that's more end of life treatment and decision making as opposed to quality of life, and really something that's is just like another provider taking care of your child or whoever your loved one is, right from the beginning, and putting a plan in place so that you have another set of eyes looking after them.
I mean, Sabrina, yes and no. Yes, in that I find there's definitely a stigma about palliative care. That's why our team's name is the Quality of Life and Advanced Care Planning Team. I think that stigma hugely exists, and especially in pediatrics. But I think everywhere, you know, it's kind of palliative care is when you've kind of given up, which, you know, I personally would argue is very far from the truth. But I also find that it's one of those things where it's like, you don't know whose job it is because of this, because there are so many people who are doing it. It's not like the family doctor is like, oh yeah, this is 100% on me. It's not like the specialist or developmental pediatrician is like, oh yeah, this is on me. And oftentimes the stress of healthcare, again, at no one's fault, there often isn't the time. You're dealing with treating pain, treating reflux, looking at feeding tubes, eyesight, chair seating, all of those things. And often that time isn't made for these conversations. And so I think it's a little bit of column A that you describe, but also column B of it, just the timing not happening. And I'm going to talk a little bit about barriers, and I think that should answer your question as well. So for me, the ideal person is someone who has a longitudinal relationship with the patient, understands the trajectory of the disease or condition. You guys may remember this nurse practitioner. She works in the Rett syndrome clinic at Bloorview.
Yeah.
She would be my ideal. Sees the patient at a time of stability, and has the time. This goes to your comment, Sabrina, has the time to engage. So a length of appointment, regular follow-up. And those would be the optimal characteristics for me. Of the actual discussion, I would hope these discussions would be individual to the patient, their family, their circumstances, explores what the patient and family understands, and remembering the patient, especially with children with neurodevelopmental conditions. They have an experience too. There's so much we can learn from them, verbal or not. And so understanding what's important to our patients, exploring hopes, worries, values, beliefs. I say that in one quick line, but that can take me an hour and a half on a good day. Understand the critical abilities for the child's quality of life. What ability, if your child didn't have, what ability would have such an impact on their quality of life? And this may help you in the future, should that ability waver. Uses uncertainty to our advantage. Uncertainty means that we should be talking about all these things. It's not going to make them happen, but it means they may happen. I think advanced care planning discussions should empower families. This is giving you control. This is allowing you to say what you want if your child were to be unwell, if you were to become unwell. This is, I think, an empowering process. For me, it should focus on quality of life at every stage, and it frames the conversation in a holistic manner. Barriers. So this kind of gets to your question. What are the major barriers? Is it you as a family? Are you not bringing it up because you don't want to? Is it the healthcare practitioner? They're not bringing it up? What stops these conversations from happening? I think personally, it's the healthcare provider. And in my healthcare provider version of this talk, I talk about how the barriers are us, and how we need to make more time, that families want to talk about these things, that we're not causing families to lose hope. We're not causing families to think about hard things because we know they're already thinking about them. And we get some of that from the research. So this was a study in the Journal of Critical Care Medicine back in 2018, and it looked at advanced care planning and parent-reported end-of-life outcomes in children, adolescents, and young adults with complex chronic conditions. And what we were told, and these are some quotes from the paper, is that parents of children, adolescents, and young adults with complex chronic conditions highly value advanced care planning early in the illness course. Advanced care planning is associated with improved patient-reported end-of-life outcomes for this population, including superior quality of life. Now, this is talking about end-of-life care. And fortunately, we know in the Rett syndrome population, the majority of children will continue to live well past their 18th birthday, and it's not end of life. So I don't think I have a slide in it here, but myself and Andrea Hoffman, I'm trying to think if Erin Brandon was on the paper or not. I believe she may have been. We looked at the cerebral palsy population and tried to get, their view of advanced care planning conversations. And they are, again, a population where some children do die before the age of 18, but many and most, like the children with a diagnosis of Rett syndrome, will not. And we got the exact same answers. No change at all. And so we kind of created this holistic advanced care planning model, which is what we based our postcard on. And this talks about all the different holistic ways to delve into advanced care planning so that we are serving all populations and not just children who are kind of at risk of death before 18. And if you look here, this is for you, Barb, in the long-term caregiver education support and planning, discussions about who will look after the individual if the current caregivers become unable to do so. And that is one of the big things I find, especially with families as children start to get older and live longer with all the technology we have, that we really need to be looking at what happens if a caregiver is not able to care for their child. Because as Barb, you've witnessed, and I'm sure many of you who are watching this will know, that is a fear that we hear a lot from different families. Hard to discuss topics. This is advanced care planning for me. And these are the topics that I'd say, we have to be talking about. What if your child were to become very, very unwell? This is not talking about death, but needing to be in an ICU, needing to be admitted to hospital, a really bad pneumonia, an aspiration, COVID. What if primary caregivers become very unwell, as Barbie unfortunately shared with us, or in a worst case scenario were to die or not be kind of present in any way? What if your child was not able to live with you anymore? What if a child was felt to have a really poor quality of life? So if we're looking at that quality of life scale, then we're really kind of dipping down past the neutral into suffering. What do we do then? What are the next steps? I don't know if any of you are kind of able to share. I know we have a smaller audience, but what topics are hard for you to talk about? You have any questions about some of these topics that I've mentioned?
Well, I think that none of us know when we're going to die. None of us at all. And the worst possible thing is not to do advanced care planning, because the advanced care planning has to happen when you're in the shock, when your loved one has just died. And that's not a time, that's not a good time to try and figure it out. It's much easier to do that earlier on. So I think it's really important for yourself and for the memory of your child as well. So.
I couldn't agree more. Larry, you're asking me about helping how to introduce the questions of fulfilling child's last wishes. I've got, I don't know, Sabrina, if you can make sure to take down his email for me, because I not sure I have. I'll send you.
I have it.
And
Yes,
I'll send you
I
a
have it.
link to our palliative care education rounds that I wonder if you'll be interested in. So thank you so much for that, Barb. I could not agree more. And I think this is why these are topics of conversation that I hope within the Rett syndrome population and community, but also for anyone living with a child with a chronic disease, that we can try to empower both families and healthcare professionals to talk about this more, so that to the best of our abilities, we're able to try to preserve quality of life of the children that we care for and love.
This was a wonderful talk, very informative, a lot to reflect on, and I can't wait to talk to my husband tonight about this. This is our conversations. Yeah, no, this was incredible. Thank you so much, Dr. Joe, for doing this for us and for our community, and for Barb as well for everything that you shared with us, and how you created Mark's legacy is just remarkable. And Larry, thank you so much. It was a pleasure to meet you, and I'm so glad that you joined us and really brought a lot to our conversation today. I don't know if anybody has any other questions for Dr. Joe before we sign off. Like I mentioned at the beginning of the talk, we have a lot of resources on our website. We've also are in partnership with I would like to mention this, in partnership with the University of Manitoba, specifically Dr. Restagar's laboratory. We are working with her, and we've developed what's called the Brain Bank repository. And if you would like to do organ donation and donate your loved one's organs to her laboratory, she'll do research on Rett syndrome, on the specimens and the tissues. And we have all that information on our website with consents, who to contact, any transition of life information, anything like that you would need. We do have the resources, so please reach out. And if you have any questions or concerns, please let me know. I'm available by email, and all my information is on the website as well.
I think that this webinar has been really helpful, and I think that I hope this is an ongoing conversation, because it's a difficult one whenever you're talking about death and dying, or how to improve quality of life for people that have difficulty doing that on their own, that really need us to provide assistance with that. And I think that the problem to have something on a website, I mean, it's wonderful to have something on the website, but if the conversations don't continue on a regular basis and the education around it, then people will be caught like I was, where I didn't expect my son to die and he did. And you know, then what do you do? So I think that it's really important to keep the conversation going on this.
I couldn't agree more. Definitely something that we have to continue to talk about, advertise, and not so much advertise, but have available for families. And when we do our conferences, we're going to be looking at doing stuff like that and providing more information and one-on-one talks with families. So just to let them know what's available to them and what kind of legacy work they could be doing for their loved one as part of advanced care planning.
Yeah, Barb, don't get me started talking about legacy work. I'll talk your ear off.
We should have you back to do a presentation on legacy work. I would love that.
Offer accepted.
Well, hopefully you'll be in person next time at our next conference. That would be so lovely.
Fingers crossed.
Okay, I'm going to wrap up the session. Thank you all so much for coming and for joining us. And thanks again, Dr. Humphries. Appreciate it.
Thank you.
Okay, bye everybody. Take care.
Thank you. Good night.
Bye.